Dr. Crosby is currently a medical epidemiologist on the surveillance team in the Etiology and Surveillance Branch of the Division of Violence Prevention. Please join me in welcoming Dr. Alex Crosby.
All right, well, good afternoon again. In case you forgot who I was 5 minutes ago or from this morning, then I'm Alex Crosby again. But thank you for the introduction. She didn't read through the whole thing, so that was good, so you guys can remember it. Now, I know, what the topic that is supposed to be presented this afternoon, the Association of Alcohol and Suicide, is a research project that we did at CDC. And really, the presentation of this research project probably takes about 20 to 25 minutes. Now, this whole session is like an hour and a half. So I know that some of you, that are sitting up front, paid, big money for these front row seats, like you go to a Beyonce concert or something. I mean, you pay like $1,000 for the front row seat. So I didn't want to come up and, talk for 25 minutes and then be done, because I know how it is. You go to a concert, you pay, $500, $6,000. I've never gone to a concert where I paid that much. But, you pay that much money, the person does a 30-minute show, and you're like, wait. Now, somebody's going to have to give me back some of my money because I paid all of this. So I have added on a piece to this for this afternoon, so I think I can keep you for about an hour and a half. But this part on alcohol and suicide by ethnicity is probably about 25 to 30 minutes. I'm going to tell you a little bit about this research project, tell you a little bit about how it might apply to some of the things that you might be doing. And then I'm going to talk, the second part is going to be about some initiatives that the Centers for Disease Control is doing in the area of suicide. And one of the things, and when I get to it, of course, I'll let you know, is that we're trying to now look for some new approaches to dealing with the area of suicide prevention. One of the things that I have considered, so I'm now giving you kind of the preamble for part two. One of the things that many folks have looked at as sort of a weakness in regards to public health and how we've approached a number of different health problems is we oftentimes focus on the risk factors. And we talk about, here's a risk factor for this disease, here's a risk factor for that disease, here's a risk factor over here. But you don't really talk about, with many diseases, many folks don't get involved in it because there's protective factors that counteract the risk factors. And so one of the things that we're doing with CDC, that we've just started this strategic direction, is focusing on some of the protective factors for suicide prevention. So I'm going to talk a little bit about that in the second part, and you can see some of the areas that we're trying to emphasize in regards to looking for protective factors. Not only how do you measure it, because that's a big deal too, is you got to know how you measure for some of these protective factors, but then how do you put them into prevention programs? How do you develop programs? You can develop some programs that try to lower risk, but you can also develop programs that enhance protection. So how do we now develop some of the programs that enhance protection? So I'll talk about that in part two, so you can't leave early. Plus you can't leave early because you need those education, so you can't leave early anyway. But just so you know, that's the second part that's coming along. As I mentioned, this was a research project that we did. Let me move on to the next part, actually. That's my disclosure statement. The learning objectives at the conclusion of this session should be able to describe why suicide is an important health problem. If you were there this morning, you already know, it's one of the leading causes of death. Not only deaths, but it also has an impact in terms of non-fatal suicide attempts, suicidal behavior. So it's an important health problem from that aspect, and that's an even bigger burden on our society than just the deaths. So you're able to describe why it's an important health problem. Discuss how the association of alcohol misuse and suicide varies by race, ethnicity, and then also characterize the National Violent Death Reporting System. Let me stop there for just a minute. The National Violent Death Reporting System, I'm going to describe it a little bit more in just a minute, is a system that CDC helped develop about 6 or 7 years ago to try to capture better information about suicide deaths that occur across the United States. Oftentimes, when states were looking at suicides and the risk factors for suicide, they were usually limited to what's on a death certificate. Now, I'm not sure how many of you have ever worked with death certificates, but they don't have too much more than name, rank, and serial number on them. They got what the person died from, they got their age, they got sex, whether they're male or female, they got an age, and they got the method. But there's not much in terms of what might have been some precipitating factors, what might have been some things that led that person to engage in suicidal behavior. It doesn't talk about whether the person had some sort of substance abuse problem, whether they had a psychiatric problem, whether they had a relationship that just broke up, marriage problem, job problem, relationship problem, had they been suffering with other kinds of things in their family. Doesn't have any of that stuff. So that's part of what this violent death reporting system was designed to do. It's to try to take a look at a broader array of factors. So what this system does is it puts together death certificate data with medical examiner and coroner data, and oftentimes they do some sort of investigation and ask some questions of the proxy. It also includes some law enforcement data. Again, they may have interviewed someone, and that kind of information would be in this system. It also has toxicology information. So if the person had alcohol just before they died, or some other substance, it would have the toxicology levels for that on there. And many states have added in some other information in there too. For example, it can look at child maltreatment related. So it can look at maybe some social service records that might be in there, or a child fatality review. That can be in there too. And some states have the ability, depending upon what might be a specific area of interest that fits under a violent death, that those states can add in supplemental information in there to it. The other good news about that is, while it doesn't cover, even though we call it national, because that's our goal, is to get it to all 50 states, right now we don't have it in all 50 states. We've got it in 18 states, but Michigan is one. Michigan just got awarded last year. So while they may not have any data right now, within a few months, probably the early part of next year, or at least by spring of next year, they will start collecting some data. So the Michigan State Health Department, under Pat Smith, I think she heads the injury prevention program there, will be someone that maybe you can contact regarding some information that may be relevant to Wayne County and Detroit, as the system moves along. So some good news in that regard. Violence, just as it's defined by the World Health Organization, just to kind of let everybody know, because many people, when they think of violence, they think of interpersonal violence, one person against another. They never think of suicide as a form of violence, but it really is violence that you've done to yourself. And so that's part of why I put this definition up there, so people will understand. When we talk about violence prevention at CDC, and I work in the Division of Violence Prevention, why suicide is one of the things that we help deal with. So not only do we deal with that, intimate partner violence, child abuse, we deal with youth interpersonal violence. We're starting to do some work in elder abuse too, which is definitely a growing area. So suicide fits in as part of that. It's the intentional use of physical force or power, threatened or actual, against oneself. That's where the suicidal behavior fits in, or against another person, or against a group or a community. And you can see how the kind of dividing up of the different forms of violence: interpersonal, which is homicide or assault, and then self-directed, which can be suicide, and then non-fatal suicidal behavior. Excessive alcohol consumption is the third leading modifiable behavioral risk factor. When we measure some of the leading causes of preventable forms of death, as you can imagine, tobacco is the number one in there, but then also obesity and sedentary lifestyle is generally number two, and then alcohol is number three. And it's connected to a wide range of different kinds of health outcomes, adverse health count, unintentional injuries, for which motor vehicle is a big area in that, and then also in violence. In 2001, estimated that over 75,000 alcohol attributable deaths occurred in the United States, and then 2.3 million years of potential life lost, and almost 7,000 suicides related to alcohol. Those of you who are not familiar with the term years of potential life lost, the way that's calculated is you can do it according to certain ages, but generally one of the ways that you can do it is you can say, well, what's the average life expectancy in the United States? And if that average life expectancy, I think it's about 78, but let's say, for example, it was 75 years. You could say the average life expectancy in the United States is 75 years. If somebody dies at the age of 20, they lost 55 years of potential life. If they just lived to the average, they lost 55 years. And so one of the things that you can do is you can go back and look at, for a given year, what are all the different causes of death, and then what age did people die from those different causes? And you can look at all those things and you can say, we've got folks that are dying before they reached just that average life expectancy. And we know there's some people that live much longer than that. But you can go back and take a look at that. So you can calculate all of those years of potential life lost just based on that average. And when you look especially at a cause of death that disproportionately affects young people, you will see that it has a large number in regards to that years of potential life lost as suicide and as alcohol. I've already talked about suicide, the 11th leading cause of death in the United States, over 33,000 deaths in that year. And the rates and the factors associated with suicide do vary widely among different ethnic and racial populations. So it's not something that, and I was trying to talk about this a little bit this morning, in which you can paint a broad brush about suicide affects everybody the same. It doesn't. And so when you start to look at it and you start to look at some of the details of how suicide affects different populations, you also want to take a look at what are some of the risk factors and how these risk factors may differentially affect different populations. And that's what our study was trying to do. Here is suicide as the 11th leading cause of death. I already talked about that. Here's when you look at the leading causes of death by different age groups in the United States. So overall, when you add on everybody's all the causes of death for all the age groups, that's where suicide is the 11th leading cause of death. But when you look at specific age groups, you can see that among 15 to 19-year-olds, among 20 to 29-year-olds, suicide is the 3rd leading cause of death. So it disproportionately affects young people, even though in some places the highest rates are among those that are over 65. When you talk about where it is as a leading cause of death, especially when you talk about from 10 up to 49, it's one of the top 4 in those age groups. And even when you get into the 50s, it's still the 8th leading cause of death. So it disproportionately affects young folks. So it's definitely something that we need to pay attention to, young folks and into middle age. These are the suicide rates. Let me see. I don't know if maybe I do have to walk a little bit back and forth. I'll walk back and forth. When you look at suicide rates by different populations, different racial and ethnic populations, you can see that the suicide rates are not all the same. And so you've got to pay attention to, in some cases, different age groups in different populations. And let me talk a little bit about what these patterns look like. When you look among Native Americans, which is American Indian and Alaskan Natives, and you look at their suicide rates tend to be very high among adolescents and young adults, but they come way down when you get among the elderly. Different pattern when you look at European American, that's white non-Hispanics, where the suicide rates tend to be higher out here in the middle-aged and then coming on up into the older adults. Different patterns there. When you look among African Americans, which is in the magenta, the highest rates, similar, although not as high as among Native Americans, the highest rates are among adolescents and young adults, and then they're coming down after that. Looks fairly flat among Latinos, although a little bit of an increase when you get among older adults, and then among Asians, the highest rates are among the elderly. So you've got 5 different populations here when you just look at it by race and ethnicity, and some different patterns. And so if you're thinking about a prevention program, this is another thing, you've got to think about, well, which population might I be focusing on? And if I'm trying to prevent deaths due to suicide, it might be in some groups, I focus on adolescents and young adults, whereas in other groups, maybe it's older adults that I deal with. You got to